Assalamu alaikum. The clinical day. First scenario, Mr. John Smith, 45 years, male, presented with knee pain. Please take history and examine the patient. Address his all concerns. Ready, Dr. Huda and Dr. Mayada?
Yes.
Okay, here you go.
Hello, my name is Dr. Maida, one of the medical doctors in the clinic today. Can I confirm your name and your date of birth, please?
Yes, my name is John Smith, 45 years old.
What do you want me to call you?
John, doctor.
Okay, John. Can you tell me in your words what bring you to the hospital today?
Yes, I have a knee pain and came to know the reason for it.
Mm-hmm. Okay. Since when you have this pain?
I have it for 2 days.
For 2 days. Okay. Do you have any injury at all?
No, doctor.
Okay. Can you tell me exactly where is the pain in the knee?
Yes, it's exactly in my right knee.
In the right knee, whole knee.
Whole knee, yes.
Is it associated with any swelling?
Yes, doctor.
Mm-hmm. Okay. Can you prescribe this pain for me? How it looks like?
It's severe pain, doctor. I can't describe it much, but yeah, it's severe pain.
Okay. If you prescribe it, like, is it like a sharp pain, like a
Yes.
knife, or okay?
Yes, it's sharp. Yes, doctor.
Mm-hmm. Is the pain aggravated by any movement?
Yes, I think it's with movement, with rest, the same, but yes, with movement more.
Okay. If I give you grade of pain from 0 to 10, as 0 is no pain and 10 is the maximum 10 you ever had, how you can grade your pain?
7, doctor.
7. Oh, it's quite severe, isn't it?
Yes, doctor.
Mm-hmm. Okay. I'm so sorry for that. Can you? So is this the first time to have this pain, or you had it before?
No, I had it before. I diagnosed with gout.
Okay.
1 year ago.
1 year.
But this pain is different, doctor.
Okay. How it differ from your previous pain?
It's more of a sharp, more severe pain.
Okay. And you said it's associated with the swelling in your knee as well.
Yes, doctor.
Any redness around the knee?
Yes, there is redness.
Okay. You said that you've been diagnosed with gout previously. Do you take any medication for that?
No, I'm not using now any medication. Previously, I was using medication such as colchicine, but now no.
Okay. Apart from this pain, do you have any fever?
Yes, I felt that there is some rising in my body temperature.
Okay. And anything else you want to tell me about this pain?
No, doctor, it's just a sharp pain, severe pain. No, nothing else.
Okay. How this affecting your daily life, your daily living?
Yes, it's affected me a lot, doctor. This because of pain, and I could not even manage to stand on my leg.
Okay. So for the daily activities, you can't stand, and you do you climb the stairs? Okay. Okay. So it's quite severe sound to me.
Yes, doctor.
Okay. Let me go apart from this knee pain. I want to ask you some questions, and if it's that okay, just you can reply to me yes or no. Is that okay?
Yes, okay, doctor.
You said you have fever. And a shortness of breath.
No difficulty in breathing, no.
Okay. Any raising in your heartbeat?
No, doctor.
Okay. Do you have any headaches?
Yes, I think it's more of dull headache all over my head.
Mm-hmm.
Yes.
Since when you have these headaches?
I have it for long time.
Mm-hmm.
Headache. I think I have also elevated blood pressure. So I think it's because of my blood pressure. I don't know.
Okay, so you've been diagnosed with high blood pressure before, or this new?
Yes, doctor. I've been diagnosed with high blood pressure.
Okay, you take any medication for that?
Yes, I use furosemide tablet.
Mm-hmm.
Yes, I'm regularly using it, doctor.
Okay, and is it regulating your symptoms or no?
Um, you mean the headache?
I mean the blood pressure.
Yes, I checked it recently. I think it's okay.
Okay, so why you think this headache related to your high blood pressure?
I don't know. I just assume that, doctor.
Okay, since when you have these headaches?
Since 1 year, maybe I
Oh,
have it on and off. Yes.
on and off. Okay,
Mm.
so it's not something new.
No, not new.
Okay, any blurring of vision at all?
No, doctor.
Okay, do you have any stiffness? I mean, when you walk in the morning, do you have any body stiffness?
No, doctor.
Mm-hmm. Do you have any other joint pain apart from the knee?
No, doctor.
Okay. And as I understand, this is the first time you have this, this is the second time you have the knee pain.
Yes, I have previously knee pain diagnosed me with gout, but this is a new, doctor. New pain. It's different.
Something different. Okay. Do you have any change in your bowel symptoms, bowel habits, sorry?
No, doctor.
Okay. Do you throw up or feeling like you want to throw up?
Yes, maybe feeling sick, but never
Mhm.
throw up.
Mhm. Okay. And do you have any urinary symptoms?
No,
Any
no
change
change
in
in
your water work?
no change in my water work. No.
Okay. So just I want to ask, you said to me that just I want to review up for your medical history. Apart from furosemide, do you take any medications at all?
No, doctor.
Okay. Okay. Only the diuretics. This the furosemide.
Yes.
That's it. And I think you mentioned colchicine. That was
Yes. Yes.
okay.
Previously, I used colchicine, but now no.
Okay. Any family history of knee problems I should be aware of?
No, doctor.
Okay. Uh, what do you do for a living?
Teacher.
Teacher. And it sounds that this pain affecting your daily life because you are not working and everything, yeah?
Yes, doctor.
Okay, I'm so sorry for that. We'll try to help regarding this issue. And do you smoke?
Yes.
How many cigarettes?
5 cigarettes a day for 5 years.
For the last 5 years? Um, I think it's a good idea if you think about quitting smoking because it affects our health in some way. If you think about it, I will refer you to the smoking cessation clinic.
Yes,
Uh,
thank
what about alcohol?
you. No, doctor, I don't drink. Go ahead.
Yeah, you don't drink alcohol. Okay, at the moment, I'm gonna examine you, and during examination, if I remember to questioning you, I can ask you questions. Is that okay?
Yes, doctor.
Okay. For examination, I will start examination with general look. I will inspect the knee for visible deformities. swelling, bruising, redness, or asymmetry between the two knees?
Yes, positive swelling and redness with the hotness and tenderness in the right knee.
Mhm. Then I look for sign of muscle wasting or atrophy.
Yes, negative.
Okay. Then I start with palpitation. I will palpate the knee joint to assess tenderness and warmth and swelling. Then I will check for the for patellofemoral pain or dislocation, if there is any dislocation.
Negative.
Okay. Also, I will examine for the meniscus, for the medial and lateral meniscus. And then I will examine for the ligament injuries, if there is any ligamental injuries.
Negative, doctor.
Okay. I will ask you to first assess active and passive range of movement. I will flexion and extension.
Yes, limited movement even on passive movement.
Is there is any crepitus?
Negative crepitation.
Okay. And then I want to general examination if there is any skin rash, anything.
No, negative.
Okay.
Where you will check the skin rash exactly? Any
I will
specific?
I will examine skin rash for all the lower limbs.
Negative in the lower limbs. No.
Okay. And then I will general examination for the patient. I will start by general look for the patient, looking for any pallor, any sign of infection.
No pallor, but he look slightly sick and fatigue.
Okay. Then I will examine the generally as well. You said there is no pallor, no jaundice. Looking for this examination of the face, I will examine the chest for. I will examine chest for palpitation. Sorry, I will ask for the vital sign.
Yes, body temperature 37.8. Blood pressure and pulse rate is normal, within normal.
Was normal. Then I will do like general examination. I will examine heart, examine the bibasal, if there is any bibasal crepitation for the chest, abdominal examination, looking for any mass, looking for any intra-abdominal mass or tenderness, if there is anything positive.
Negative.
Okay. So, okay, from the examination and I did with you, it
2
sounds
minutes left.
Okay, so it sounds to me that this knee, as it's only one knee, I need to roll out there is no infection in your knee. Okay, so what we're gonna do that first I will do an X-ray to roll out there is no fraction, there is no injury inside the inside the knee, and then I may need to go further for MRI to roll out there is no ligamental injuries as well. And the other thing that we need to have a knee aspiration, that we need to take some fluid from the knee to examine this under the microscope to find out if this gout or it's infection. We need to at the moment I think I will keep you in the hospital at least for overnight, so we have this investigation done, and after that we'll give you some pain medication at the moment, and then we'll go further for this investigation to find out what causing this knee. If that sound okay?
Yes, okay, doctor, thank you.
Okay, thank you. I have time still?
Yeah, 30 seconds.
Okay. Also, one of the investigation we need to do is ultrasound for the joint, for the effusion as well, to find out. So this is the investigation we may need to do.
Any history you want to take? Any question you want to ask?
Okay. So
Any differential you want to roll out?
okay. My differential here, gouty and
Okay.
septic arthritis.
Time is up. Time's up. Let's go to the exam question. Dr. Wahuda, please start.
Okay, doctor. So differential diagnosis.
Okay, for this, first, this lady, Mr. John presented with this knee joint pain. He has a background of gout previously, and now he presented with this knee pain. My differential diagnosis, first, I need to rule out septic arthritis. And then the other differential may be gout as well, because he has a risk factor of medication as he's taking furosemide. And this is the main differential diagnosis to me. He has no history of he has no history of trauma, so unlikely to be traumatic.
Yes.
Mhm.
Okay. So, what in history make you think you have a septic arthritis? Your top differential. Anything in history could point to septic arthritis other than fever and feeling sick?
No, in fact,
Okay.
no other point, but the way the presentation of the joint pain, it's acute
Yes.
type of pain, and this is the only thing.
Okay. So the investigation you will send for the patient.
First, I will send an X-ray to rule out there is no injuries. Then we need knee aspiration. I will send for gout and for sepsis, for sepsis screen as well. I will send an for the effusion also. I can do an ultrasound, an MRI to rule out there is no ligamental tear or injuries.
Okay. And the management plan for this patient?
At the moment, because this patient is unable, severe pain, I will, before start antibiotic, I will admit the patient for pain management, and then I will, I will do this investigation, and then if we think about sepsis, we can start her IV antibiotic for the, and if not, just pain management.
Okay. And which are the common infective causes of arthritis?
I still remember.
Right. Okay. Thank you, doctor.
Thank you.
Still 2 minutes. Okay, let's start as approach for any case scenario. You said the presentation, the differential, then he will ask you how you investigate this patient.
Yeah. We said the investigation, yeah.
You said already the investigation?
Yeah, we said the investigation, X-ray, MRI, ultrasound.
No. Be always systematic. Start by blood test, general
General
sign.
investigation.
Yeah.
General
Okay, go ahead.
Yeah. So general investigation with blood tests, including white blood cell, including full blood count, liver function, kidney function, and kidney function, yeah. Then specific investigation, X-ray for the knee, ultrasound for the joint effusion, MRI for ligamental injury, and joint aspiration.
Okay, and on inspiration of joint, looking for
Aspiration, first looking for septic joint, roll out septic joint, and for gout.
Yeah, how to roll out septic joint in the aspiration.
Yeah.
This is Dr. Huda question. How to roll it out?
Yes, looking for the gram stain and doing culture.
And what else? Culture, gram stain, and what else?
And for
Culture
gout,
takes 3 days. No, wait. Culture
Mm.
and gram stain, it might take long time, right?
yes,
From
white blood
inspection, by
cells
inspection
count.
itself.
Yes,
No.
for
From the aspiration itself. What test can help you to say this is inflammatory or infection?
looking for the white blood cells count, maybe
Perfect. Yes. Leukocytes.
leukocytes count. Yes,
Yeah,
more than, I don't know the number, but
50,000.
mm,
Okay, this is septic arthritis. And the culture, of course, we will send, but it takes time. That's why we will look for the leukocytic count. Okay. You mentioned also the image. You mentioned the MRI for the ligament, right?
Mm.
But initially we'll do the X-ray. How to manage this patient?
This patient need hospital admission because the pain is severe, quite severe. Now I will admit this patient to the hospital, manage the pain management. After we take the aspiration and we think about, we do therapy with white blood cell. If we are thinking about infection, we'll start antibiotic, IV antibiotic.
Okay,
If not,
I will ask you, okay, one question before starting the aspiration or doing the aspiration. What is importantly to do? What test is importantly to do before any aspiration?
I couldn't understand.
How you will go to aspirate a joint by test before doing the aspiration? What test is important to do before the aspiration? You will go blindly without checking
The
bleed?
fluctuating, this is the for fusion. Normally we did the
No, this is not my
with
question.
ultrasound.
No, blood test to do to be sure that no complication will happen, like hematoma or bleeding, hematemesis.
Okay. Coagulation
Yeah,
profile.
coagulation profile. Okay, go ahead with the management again.
Okay. So yeah, you want me to do the management? Okay. So management, patient admission, pain management, and after respiration, we think about infection. We'll start empirical antibiotic.
Perfect. This is as septic arthritis management. What other management you could do for this patient?
Also, we can discuss this with the orthopedic team.
Perfect. So you will call a doctor
the
now or a specialty.
yeah.
So how you will start management before calling the orthopedic only? What you will call also? What teams? What's called?
PCOT, physiotherapist. This is the teams we involve.
What is this approach called?
MDT.
Yeah, perfect. You have to mention MDT before managing such patient, right?
Yeah.
What are the team involved in this patient?
Apart from physiotherapist and orthopedic, orthopedic, I will. If I am thinking about gout rheumatology team as well,
Perfect.
I will involve the rheumatology in this case.
What's important team here? You suspect
if it is if it is septic arthritis, I think the rheumatology. Sorry, the orthopedic, because this patient may need
you
joint.
mentioned the ortho, the aspiration, the IR, radiology intervention for aspiration, ultrasound guided. There is one team important here for the antibiotics and notification. You suspect septic, right?
Okay, so microbiology mean?
And ID team or the infectious disease. You don't know what the organism. Yeah, it could be gonococcal, right? You don't know till now because you didn't screen about it, but it's one of the possibility, right? Gonococcal. Isn't?
But Okay. I think if infectious, we call them if we have a specific diagnosis, then we call them.
But septic
But
arthritis is one of the
or
serious infections.
mm,
You have to start antibiotics according to guidelines, and you should start broad spectrum. If this patient delayed in the management, it could be causing sepsis and septic shock, right? Bacteremia and septic shock.
mm,
So you have to involve the infectious disease team for proper antibiotics choice, right? Okay.
mm,
So this is, you have to say a multidisciplinary approach. And according to the culture, we will downgrade the antibiotics according to the result. And antibiotics, as you said, and
mm.
looking for the cause. Why this patient is having septic arthritis? What do you think? This is one of the
Explore
specific tests.
factors that if he's a blood user, I think I need to
So
ask about this. If he's
this is history-wise, no, investigation-wise, what you will do?
for
You
what?
already aspirated the joint. What other screening you will do? You will send blood culture, right? Blood culture, urine culture. It might be from urinary tract. We are not sure also about the source till now because the history wasn't conclusive. But you have to send for blood culture along with septic aspiration
Screening
joint.
with
Yeah,
okay.
yeah, septic screening exactly. So this is how to answer in systemic way, because if you
Mm,
answer only on the point of septic arthritis, what about the screening? You have to know the cause. This patient will be treated and he will come back again with septic arthritis in another joint because you didn't treat the source. You didn't control the source of infection.
you're right.
Okay, yeah. So let's hear Dr. Hoda comment, please, Dr. Hoda. Well done, Dr. Mayada. Let's hear the comment, then I will comment.
This is a 45-year-old male presented with acute onset of knee pain on background of long history of gout. Regarding the history, he has presented with high temperature, swelling, with feeling sick and fatigue. So the top differential diagnosis, and explore throughout the history and explore more about any risky behavior such as needle use or signs and symptoms of needling, decreased body weight, lumps or bumps, more of an HIV symptoms, travel history, risky behavior. So the differential would be septic arthritis. The second differential could be acute gout, could be trauma, could be crystal arthropathy if we ask more about the weight, any weight changes, weight gain. So the top differential would be septic arthritis or a flare of gout. In the history, it's important to exclude or to know if this gout is well controlled or not. So explore more about the drug history. He mentioned that he had been using furosemide and it's one of the precipitating factor for gout. So maybe involvement of heart doctor to recommend other medication. I think it's the best medication in this case for hypertension in gouty patient would be losartan. Explore more about diet and throughout the management involvement of a dietitian. Ask about the diet, mainly about meat and seafood, and asking more about any impairment of kidney function from the urine changing the water work, and explore more about his last blood pressure reading, any high blood sugar, any high cholesterol, asking about smoking history, alcohol also important in gouty patients. Regarding the septic arthritis throughout the history, it's he mentioned that he have a swelling, throwing up, feeling sick. So ask more about travel history, risky behavior. Yes. So examination would be starting from the main complaint, which is the knee. Look, feel, and move the knee. Also look for any gouty symptoms or signs such as the two facial scout on the ear helix, maybe asking for any hand pain, looking for any lymph node enlargement, and the investigation would be routine, complete blood count, renal function, liver function, and for sure is admission of the patient. And then investigation would be involve the routine investigation, invasive investigation would involve aspiration of joint, looking for needle negative preferences of gout, and looking for the gram stain and white blood cells count culture, maybe doing even swab for the urethral area or even rectal area blood culture, and even non-invasive would be X-ray to the joint. The treatment would be non-pharmacological. After admission, rehydration, broad spectrum antibiotic, and then antibiotic according to the blood culture. Then non-pharmacological, educate the patient, stop smoking, alcohol, involve a dietitian. Then a pharmacological will depend. If it's septic, then analgesia, rehydration, IV fluid, antibiotic. If it's a gout, it's mainly acute treatment with analgesia, non-steroidal anti-inflammatory drug. And yes, this is my notes.
Sorry, ممكن I wanted to ask دكتورة هدى one question.
Yes.
Yes, go ahead.
You said the risk behavior and the travel history and HIV. Why this for septic arthritis, how HIV can affect the joint here and the travel history?
Yes, travel history may be more of Lyme disease or even, yes, non-gonococcal arthritis, bacterial infection, or could be even gonococcal arthritis, which is more involvement of a risky behavior, gonococcal arthritis, sexual history, needle use, and mycobacterial arthritis, even important in the travel history, Lyme disease in the travel history. Even if
Lyme disease causes septic arthritis or only reactive arthritis with fever?
Yes, it's one of the differential of infective causes of arthritis. So the common infective causes of arthritis could be non-gonococcal arthritis, which is the bacterial cause, such as Staph aureus or Streptococcus. This is the non-gonococcal. Gonococcal arthritis, mycobacterial arthritis, and the Lyme disease. It's arthritis, a late complication of Lyme disease.
So you mean here, when I go to approach to this case, I will decide this is mechanical or inflammatory. Then if I say this mechanical, I will go with the pathway of infection or gout or pseudo-gout. So
Yes,
in this septic arthritis, I will ask about how the organism reaches the knee, either by travel history or infection by cannula, as you told me before, or streptococcal or Lyme disease. Is that right?
Yes, exactly.
The doctor, from her history, she get that it's mainly a mechanical arthritis, not an inflammatory. So important on his background of gout to exclude any any flare of gout, asking about the drugs, the diet, lifestyle, and then explore more about the reason of septic arthritis, any travel, risky behavior. Yes.
Yes, perfect, Dr. Huda. Thank you. You prepared the topic well and you explain it in a good way. I guess Dr. Mayada reached to the diagnosis. However, she didn't know the source. And this is in this exam, they want to know exactly why this patient is having this diagnosis. They will ask you, what do you think the cause of this septic arthritis in this patient? Sexual history here is crucial important to ask. You have to ask him about his sexual history particularly. You have a partner? Yes. Sorry for this question. You have any casual relationships? I don't know, Dr. Roda, prepare a hidden agenda in this issue or no, but it's one of the important questions. You have to ask this question, Dr. Maya. Don't forget always the infectious cases you have to screen for HIV and the screening of risk habit. As Dr. Hoda said, this is the key for the case.
Yes, if
The
she
risk
asks me
habit.
and the
Yeah,
history, I will tell her that I have needle use, recent travel.
yes,
Yes.
perfect. So he has three risks now. The needle use, the travel, and the travel not not the meaning of travel only. The travel means he might have either tattooing or other risk habit or exposure to some casual relationships, local girls. All this will give you the clue for the case. Why this patient is having septic arthritis? He will ask you, the examiner, do you think this is gouty arthritis? You will say no, it's most probably septic arthritis. How do you know? From the investigation, yes, we will do the investigation, everything. This is lab wise. From the history, you have to know a lot of clues why this patient is septic, most probably rather than the gouty arthritis. Clear? This is
Yeah.
what's missed by Dr. Miyada. The sexual history, the travel history, the IVUs, the alcohol already she has.
Very important. It's very
Yeah,
important part. Yeah.
it's okay. We are learning from these mistakes. Whenever you're deficient in certain point, next time you will avoid it and you will improve it. Okay.
Mm.
That's why I ask you what extra question you want to ask at the end. The sexual history, travel history, three of them is important. Sexual history, travel history, and abuse or drug or recreational drugs. And whenever you have the recreational drugs, ask him how you are using the recreational drugs, either sniffing or injection. The injection will give you the clue. Hospitalization, any procedure, if you suspect something related to the hospital. If he's immunocompromised, you have to know the constitutional symptoms. Totally, you missed that constitutional symptom. You ask about high body temperature, but how about the weight, the appetite, lumps or bumps? So please try to make it priors in asking about constitutional symptoms and all together. Don't ask one question. Fever only? No, you have to make it as a package of question. Fever, night sweats, loss of weight, loss of appetite, and lumps or bumps. It will give you a clue either serious infection, HIV, background of cancer, immunocompromised patient. You have to know all this from the constitutional symptoms. And you can say safely this is septic arthritis from the history because no missing point. But in this performance today, you miss the trigger. Why this is a septic, not gouty or maybe osteoarthritis. The good thing you approach the mechanical cause. You said, is it improving or worsening? She said, no, worse with more. So this is mechanical, clear. So you will go through the causes of mechanical as you did exactly. Trauma, one of the important. However, why you are still insisting there is ligamental issue? It's something in the joint. Trauma only can cause ligamental issue. Okay, so the MRI not for the ligament. If you want to do, you can do ultrasound for this, the joint itself, the fluid, the effusion. Patient will not have ligament injury unless he has trauma. Right or no, Dr. Mayal?
Yes, yeah.
Yeah,
You're
so it's
right.
traumatic background only.
Yeah,
But
because he's already have no trauma, so this has been excluded from the history.
yeah, so
Yeah.
don't mention the ligament issue even in the presentation. You have to mention the most important. I wrote it in the chat box in order not to miss it or to forget it. She told you how to know this septic arthritis by examination. I guess this is the answer, Dr. Hoda. The tenderness, the hotness, and the redness, right? Dr.
Yeah.
Hoda,
Yes,
I don't
right.
know. Yeah. So this is how to say this is septic arthritis, even by the look. You didn't touch. It's painful. The severity is severe, more than 5 and 7. And whenever you have pain scale more than 5, offer painkiller. You were so empathetic. You told him, yeah, it sounds so severe for you. Offer him painkiller. Do you need some painkiller right now, Mr. John? Yes, doctor, please. So just give him offer, please. Can we offer Mr. John painkiller? It's an act only, but it will give you good mark in the welfare. Okay. You have any question, Dr. Mayada?
No, thank you. Very nice case.
Yeah, it's nice and common case, by the way. And you have
I hate these joints things.
Dr. Bassem, I want
you
to ask.
reached diagnosis. Yeah, Dr. Mahid, go ahead.
I was attending one session with one mentor also, and he told us, excuse me, don't depend on one answer to direct your thinking. Because sometimes there is overlap in the stiffness. As gouty arthritis, osteoarthritis, those also, despite it is mechanical joint, but also it has some stiffness. And if you, in real practice, if you ask the patient, do you have a stiffness? He will say yes, despite he has osteoarthritis and it is in mechanical pain according to the differential diagnosis. So don't depend on one question answer to direct you in the history. Because in real practice, there is overlap mostly between the cases. So you should cover all. He says that. What's your opinion for this?
Yeah, okay. Let me clarify the point of stiffness. Whenever you have a stiffness, you have to ask the duration of stiffness. The inflammatory joint disease always takes longer. It might be more than 1 hour in early morning, right? But in other disease, yeah, there is some stiffness, but it will not be such as for the rheumatoid or inflammatory. It's particularly the rheumatoid. Okay. This is the first issue. The second issue, I believe any diseased joint is an septic focus for septic arthritis. Osteoarthritis can be a focus for septic arthritis. The rheumatoid arthritis can be a focus. The gouty arthritis also can be a focus for septic arthritis. So it might be complicated, as you said. So there is overlap. There is, if there is pathology in the joint, it could be an area for organism to invade it. You got it? Yeah.
Yes,
Another
I would-
question. Okay, Doctor.
Yes, I want to add that why I say it's why link it between septic arthritis and gout, because
Yeah.
the patient he told you that he have acute gout maybe 2 weeks ago, and he have intra-articular corticosteroid injection. He have certain injection on his knee, and this could be a source of infection. And the main source would be Staph aureus. This could be other source. Link gout with septic arthritis. Yes.
Yeah. So you mean something is triggering the infection?
Yes, other source other than the travel history, the risky behavior could be he have current intra-articular injection of corticosteroid in acute gout. They have injection, right? So it could be other source of infection, and the main
perfect.
bacteria could be Staph aureus in this case.
Yeah, perfect. So you mean particularly as a gouty arthritis case, we have to think about local invasion by either intra-articular injection.
So, yes.
Yes, by the liver. Yes, perfect. And you have also to suspect the organism. He might ask you what organism possibly in this infection. For example, if he is sexually active patient, you have to think about gonorrhea, right? Gonococcal. In IV drug use or abuser, you have to suspect what? What organism? Staphylodermis, yeah. Staphylodermis or Staphylococcus aureus, yes. So it
If
depends.
you have
Yeah, go ahead, Dr. Rose.
Yes, if you have even a prosthetic joint, maybe in other knee, could be staph epidermitis. Yes, these are the non-gonococcal cause of arthritis.
Perfect. Yes. So we have also
in real practice, Dr. Bassem, yes.
Yeah.
Real practice, Dr. Bassem, when we saw the joints of due to gouty arthritis or septic arthritis, usually the gouty, there is no redness and there is no hotness or fever. But,
there is
it is only swollen with loss of function. But in septic arthritis, there is redness and also of inflammation is there. Is that right or no?
Dr. Mahid?
Yes.
Yeah. In the gouty arthritis, there is redness and there is pain
Also,
also. Yes,
in gout,
you saw the picture of Tufai?
I saw, yes, it is a nodule like this, yeah. But
Yeah, and it's
is
very
it
red.
Mhm.
It's red also.
Okay, sir. Okay, sir.
Okay. But the nature of the pain will be less than the septic arthritis one. But it's still painful.
Mm.
Okay.
Generally, the differential diagnosis of septic arthritis will be gonococcal arthritis and the cause of
Yeah, the cause of, yes.
so
You
the
can,
cause gonococcal and stuff. Yeah, there is
yeah.
another. Okay.
And from the history, we'll know what organism you can
Mm.
link to the infection. Okay. By the
Okay.
way, if you said septic, he will ask you what organism you suspect in this patient. And according to the trigger and the source, you will say.
Mm.
Don't forget the reactive arthritis. It might be also as a differential in this patient, especially if he's, again, sexually active patient, he will have red eye and some rash in the sole or palm, plus
Mm.
the joint pain.
Mm.
Okay. So it's one of the
Yes,
reactive,
Dr. Bassem,
yeah,
reactive arthritis, it is one of the differential diagnoses of seronegative arthritis, which is
yes,
inflammatory joint pain. And still we put it in the differential diagnosis of mechanical joint pain.
yes, we can put it, especially if there is trigger, sexually
But
transmitted
in
disease.
reactive arthritis, there is no swelling or tenderness or only arthralgia.
Yeah, and
So,
it will not be the same picture and tenderness as here. Septic arthritis, because of infection, it will be the most severe pain.
Mm.
yes.
Okay.
But we should cover it in the history.
Yeah, one of the differential you should cover also hemoarthrosis, but it would be in younger patient or patient with trauma or patient with blood thinner medication. It comes also in cases, hemoarthrosis, and it's also mechanical joint pain. Clear?
Mm.
Any question else? Dr. Mayada, you can post the scenario for Dr. Hoda.
Okay.
I will try to read the comments. Okay, it started by Dr. Mahi. Yes, he said he's happy with Dr. Mayada language. Yes, I agree. She has very nice accent. I guess it's the best accent we heard. And also, she's confident while asking the questions and taking history. Okay, the next comment, Dr. Rashid or Dr. question, Dr. Rashid. Yeah, he said he didn't take permission. This is the agenda of introduction. I will take history, permission of examination like this. Trauma history, sexual, yeah, sharing needs, he's agreeing with the same our advice. Local examination, again, this is very important to mention if he asks you what the signs of infection in this patient. Plus limitation of movement, of course, passive and active. Always remember the steps of examination. Look, feel, move. Look, feel, move. The movement depends on passive and active. And this patient will be limited in every movement, either passive or active. Okay. INR, bleeding time, yes, of course. Infection control if it's notifiable disease, and infectious disease for antibiotics choice. If any history of fever, loss of weight, Dr. Salma,
I
ask
sent
double exactly.
the
Yes,
scenario. Thank you for
yes.
this comment. Thank you.
Yeah, Muslim.
I sent the scenario in the group.
Yeah, sure. Okay. Dr. Huda, your case, Mr. White or Mrs. White, 70 years old, presented with the short of breath. I will give you 2 minutes, then we can start straight away. Okay.
With
Just,
shortness of breath.
yeah, 70. It's in the chat box now.
Assalamu alaikum.
عليكم السلام دكتور رشيد.
She mentioned in the history headache for 1 year was what was
Yeah,
the
I
rationale
guess
for
it was distracted by the hypertension, Dr. Huda.
At
Because
that time, I
patient
was
was
thinking for acromegaly actually, because she said headache and hypertension
acromegaly,
together.
osteoarthritis, yeah.
Yes,
Yeah,
headache
there is.
and hypertension.
By the way, osteoarthritis is one of the mechanical cause of joint pain. You have to remember it. Dr. Huda, what's the rationale of the headache in this patient? Is it hypertension related or something related, pathological? I guess she's busy. Preparation.
Dr. Basil,
Yes.
actually, the history is very important.
Mhm.
I want to remind Dr. Mayada, and I want to remind myself also. I was listening to your meeting a lot of time, and one I can't remember her name. She's taking a very, very good history, complete history. And I find out that from the practicing, that is very important. Because now in this history, we have septic arthritis, we have also flare of gout. So we have to exclude all the triggers of septic arthritis and the triggers of the flare of gout. Dr. Mayeda is taking too much time in analysis of complaint. Like she took, I believe, 4.5 minutes or something like this in analysis of the complaint. Even the occupation of the patient is very important in gout, because if he is like a meat baker or dealing with meat, eating meat too much, she didn't ask about job. Of course, the risky behavior you mentioned. And actually, as I wrote, in any history, even if it is unrelated, if there is fever or weight loss, we have to ask about travel and risky behavior. Tuberculosis, mycoplasma is one of the causes of the septic arthritis also. HIV, sharing needle. Also, we have to explore about the complications, the renal system. A complete history is very important, even if we find the diagnosis from the first sentence, I believe.
Yes, I agree with this. We have to ask about every social details in such case. I said HIV screening risk habits should be asked one by one to this patient. Once you have suspicious of infectious disease, you have to screen it. And travel history is very important in such case. Thank you, Dr. Salma, for your comment. We are learning by practicing. That's why we are encouraging for daily practice. Thank you for the comments. Dr. Huda, are you ready?
Yes, ready.
Okay, before starting, the headache in our case or your case was due to hypertension or something else?
I just want to point that he have maybe headache due to his septic condition now, or
Okay.
link it with his blood pressure and the medication he used.
Yeah. Okay, perfect. So it's like distraction, but it's nothing important. Okay. Thank you. Let's start. Here you go, Dr. Huda.
Hello, my name is Dr. Huda, one of the doctor in the clinic today. I'm talking to Mr. White.
Yes.
Mr. White, we are here to discuss some issue related to your health condition. Is that okay with you?
Yeah.
So I have letter from your GP that you have difficulty in breathing. Can you tell me more about that?
Yes, doctor. This happened over previous several days. I mean, I was okay. I was on vacation with my husband to Spain, and when I was there, I feel like I have this short of breath. I first think this is maybe infection, and I told him to take some antibiotic or something, but this is not relief, and it's gradually increase over these 3 days.
And before this 3 days, everything was normal.
Yes, I think, yeah, I was okay.
And you told me that you have difficulty in breathing. So throughout this 3 days, is it increasing the same?
Yeah, it's increasing over these 3
Okay.
days. Yeah.
Okay. And did you do anything to relieve it other than use of antibiotic?
Actually, I need to even while we are walking, I just need to sit to have a relievement from this symptoms.
Yes. So I can understand that when you walk, you have more difficulty in breathing.
Yeah.
Right. Anything increases difficulty in breathing, like certain weather, cold or hot air.
I didn't remember. I didn't remember exactly,
Right.
but the main thing that's while I am walking.
And does it associated with any cough?
Yeah, there is cough.
Okay. And since when? Is it within the 3 days or previously?
Yeah, over these 3 days.
Right. And this cough, is it dry or associated with a phlegm?
It's dry type of cough.
Right. Okay. So with this difficulty in breathing, do you have any previously any allergy to any other substance before?
No, I have no
So,
allergies.
okay. Any maybe skin rash or
No,
eczema?
no,
Okay. Any family history of any maybe asthma or problem in their lung?
no.
Using inhaler?
For me, myself,
Yes.
no, I never been diagnosed with asthma before.
Okay. And where did you stay in these 3 days when
Yes.
these manifestations started?
Yeah, I was on. We are in hotel, and most of the time I need to stay inside the rooms because of the short of breath.
Yes, I can understand that. Okay, so it started suddenly in these 3 days.
Yeah.
Any raising in body temperature?
No.
Okay. Any yellowish discoloration of your eye?
No.
Any tummy pain?
No.
Any runny nose?
No.
Okay. And what about your husband? He stayed with you in the same hotel, right? Did he have the same complaint?
No, he was okay.
Okay. Okay. So, do you have any this difficulty in breathing? You say mainly when you do activity and you walk. So, any does it mainly wake you up from the sleep at night?
Never.
Right. And any association with any like chest pain when you're sitting or leaning forward?
No, I have no chest pain.
Okay. Any raising of your heartbeat?
Yeah, while I'm walking, yeah.
Okay. Any leg swelling?
No, I didn't observe that.
Okay. So when you stay at the hotel, do you use any air conditioner?
No, it's
or
cold. It's cold nowadays.
okay, all right. Okay. So this is the first time you have this complaint, right?
Yeah.
Right. So do you have any sometimes episode of coughing up blood?
No, this
Okay.
not happened.
Okay. And did you have a long travel? Did you travel by airplane?
Yes, I was travel with airplane. It took like 2 hours.
2 hours, right?
Yeah.
Any abnormal changing in the color of your leg? Pain, maybe sometimes.
No, my
Any
legs
blood?
is okay.
Right. Any blood clot previously?
No,
Okay. So do you have any headache?
no,
Okay. Any weakness anywhere in your body?
no.
Right. Any changing in your water work?
No.
Okay. Any frothy urine?
No, my water work is okay.
Okay. So do you have any skin rash?
No.
Okay. Any weight changes?
No.
Any lumps or bumps anywhere in your body?
No at all.
Right. So do you have any loose motion?
No.
Any changing in bowel habits?
No, my bowel is okay.
Right. So I'm sorry to ask you, Miss White, but we usually ask questions, but do you have any using of any needles or illicit drug?
No, I'm 70. No.
Any history of blood transfusion?
Maybe in the past, I don't know. I couldn't remember, in fact.
Right. Do you use any medication?
No, I'm always quite well, but apart from the paracetamol, on and off, nothing else.
Why you use paracetamol on and off sometimes?
Sometimes when I have joint pain, when I have headaches.
Okay. Do you have any joint pain now?
No.
Right. Okay. So did you check your blood, your temperature recently?
No, I didn't check, but I didn't feel like I'm feverish.
Okay. Any sweating?
No,
Any contact with someone with TB?
I don't know. No,
Right.
as far as I know.
I can understand that. So what do you do for living?
Oh, I was a teacher 20 years ago. I'm retired now.
You're retired. Okay. And do you smoke?
I never smoked in my life.
Okay. Do you drink alcohol?
Yes, I drink alcohol socially.
Socially. Okay.
Mm.
Right. Okay. So I need now to examine you, Ms. White. So first I will take a general look to the patient. Does it look sick, feel tired, sick?
No,
Right.
just obviously she's short of breath.
Right. And then I will go to her doing a respiratory examination by taking permission, wash my hand, looking to her chest for looking for any scar.
No scar.
Right. Do you have any surgery in the past?
No.
Right. Okay. Then I will do auscultation of her chest. Any added sound.
No, just clear.
Right. And then I would do chest expansion. Any limited of chest movement, mainly basally and on the apex.
No.
Okay. And then I will do percussion.
Okay.
Okay. And then I will do looking for signs of pulmonary hypertension, any elevated JVP or loud B2 or any added murmur.
No.
Okay. Then I will go to check the lymph node, any lymph node.
No.
Right. And then looking to her hand, looking for any clubbing or leukonychia, cholinekia, or any palmar erythema or
No.
joint deformities. Right. Okay. And then I will look to check the pulse of the patient and ask him. Yes.
Yeah, I'm listening.
Yes, checking the pulse, if it's tachycardia or not, regular or
Tachy. Yeah, she's tachycardia around 110.
right. And then I will go checking for proximal myopathy. And after that, I would like to check her eyes for any pallor or jaundice. And looking to her mouth by torch, looking for any cyanosis. And checking the abdomen for mainly for hepatomegaly.
No.
Okay, and then going to her leg for any pitting edema or signs of DVT, any swelling, discoloration.
No swelling.
Right. So, okay, Miss White, do you have any pets at home?
Yes, I have my dog.
Yes. And have you ever experienced any sometimes sneezing or any?
No, I have no allergies to my dog at all. He's with me for the last 20 years.
Right. Okay. Any contact with pets, with birds? Sorry.
No.
Right. Okay. So now, Miss White, can I ask you what's your concern?
What's going on? Why I'm always, yes, I'm 70, but I'm good 70. But now this nowadays this short of breath really take all everything from me. I want to know why.
Yes, I highly appreciate your concern. So, Miss White, there is mainly the reason after I'm taking history from you and examine you. So your recent traveling and these acute or recent sudden difficulty in breathing could be related to certain bug infection in your chest that leading to the complaint you have, such as difficulty in breathing, raising in your body temperature. So what we need to do is to admit you, run for you some blood tests and imaging to your chest, and then we will discuss further what will happen next.
Okay. So you think this bug?
Yes. There is certain highly possibility of being certain bug infection on your chest leading to the complaint that you have of difficulty in breathing.
Okay.
So we need to exclude it by doing some blood tests and imaging. Yes.
Okay. Okay. Thank you.
2 minutes.
Nothing in my mind to ask her and the history. No.
Okay. You asked about the occupation, the job, right?
Yes, she's retired now.
Yes. Now, yes. What you want to ask more regarding the occupation? She's retired, staying at home.
Yes,
Maybe she has some hobbies, right? I don't know the case, but always open the door for this question. You are retired before any for occupational thing, you can ask what was your job. Of course, this is not the case because she was teaching, but now she's staying, she doesn't do anything at home. Maybe she's
Yes.
doing any hobbies or she's caring. Or you ask about the pets and the birds, which is good question. But put it in your mind how also to screen about the exposure things. Okay. Okay, so you are satisfied with the history and examination. Let's start the
I see.
examiner question. Okay, Dr. Mayada, please.
Okay. So can you summarize the case?
So this is a 45 years old Miss White have
She's
sudden
not
onset
45, she's 70.
45?
70, sorry. Okay.
Okay.
70 years old Miss yes. Miss White presented with sudden onset difficulty in breathing in the last 3 days. She mentioned that she have a recent travel history by airplane. Throughout taking history from her, she mentioned that he have a sudden onset difficulty in breathing, mainly on activity associated with a dry cough, raising in body temperature.
She never mentioned to raise body temperature.
I think yes.
No.
I don't remember, but okay.
Okay.
Throughout the history, I asked her about any allergy or history of contact with.
Okay. So, what is your differential diagnosis?
So my top differential diagnosis could be a pneumonia, and yes, this is my top differential.
Okay.
The other could be Yes, could be exacerbation of asthma, other than she mentioned she have no previous history of wheezy chest, noisy chest, or using of any inhalers. Yes,
How
the
you,
third differential.
how you will investigate this lady?
Yes, I will admit this patient, run for her routine blood test from complete blood count, renal function test, liver function test, and inflammatory markers. And then I will do a chest X-ray to look for any abnormalities, maybe area of consolidation. And then I will run for her even a pulmonary function test. Yes, and maybe doing a blood culture, doing urine analysis, and investigate more about the underlying cause of her condition, maybe doing an echo study to exclude any possibility of cardiac cause or signs of pulmonary hypertension, other than the examination did not reveal any signs or symptoms of.
How we treat her?
Yes, I will admit the patient. I will treat her by giving her IV fluid, analgesia, and then maybe antibiotic according to culture and sensitivity. Yes.
Okay, thank you. So,
Still 2 minutes, Dr. Mayada. If you can ask, yeah, again, the same approach: investigation, management, differential diagnosis, and admission like this. You finish all these questions?
she said she had all the so she
The management
like
plan.
give the patient to the patient. She gave the differential diagnosis. She gave the management plan, including investigation and treatment.
Okay.
Okay, so
I will add. Sorry, Dr. Mayada. We have to ask full 5 minutes, so I will add some questions if you don't mind.
yeah,
If you don't have questions. Okay.
okay, you can ask.
Yeah. What image she mentioned? What image, Dr. Huda, you want to do for this patient?
Yes,
Chest.
mainly chest X-ray and pulmonary function test, spirometry.
Image.
And yes, chest X-ray maybe, and high
Okay.
resolution.
Yeah. But you suspect something advanced, right? So what image per choice? You said you suspect PE, right?
She never suspected.
No, the PE is less likely. My tip differential would be pneumonia, an atypical pneumonia.
Pneumonia. Okay.
Yes.
So you will go with
Pulmonary.
high resolution CT chest, right?
Yes, I will put the chest X-ray first, high resolution CT scan.
Okay,
And
perfect.
lastly, I could put D-dimer or CT angio to exclude pulmonary embolism.
Okay, that's why you are trying to make it systematic. It's blood, general, specific, bedside, and image. Finally, non-invasive tests. You mentioned the general, of course. What specific and bedside test in this patient?
Bedside test, spirometry.
And one more important test for any chest patient.
Yes, for pulse oximetry, checking the O2 saturation.
Okay, one more. In any short or long case with chest symptoms, you have to offer ABG, arterial blood gas.
Yes.
Remember it. It's a simple test, but it's very important test. Okay. Now we will go the bedside. Finish the bedside test. What?
Now
Yeah.
this is the 4 minutes finished, or
Yeah, 5 minutes. Okay, time is up. Let's.
okay,
tell me,
just
comment.
okay. So this patient, you said that the top differential diagnosis for this patient is pneumonia, isn't it?
Yes.
Okay. So as Dr. Bassett said, the investigation, did you ask about the vital sign for this patient?
Yes, it was missing. Yeah, right.
You need to ask about the vital sign of this patient to see that if this patient has, she's short of breath. You need to know about the pulse oximetry, as you said now. Is she saturated, desaturated, what's going on? Okay, and we need from the bedside things that you need ECG as well. Because in this patient, she, as far as she comes with shortness of breath, still I can't exclude heart attacks. I mean, MI is still in because females can come with MI just with shortness of breath. So still I need to have an ECG, and the ECG as a bedside also is important if this patient has PE. I will see if there is any strain patterns in the ECG or anything to indicate. ABG as bedside investigation to know if this patient has a type 1, type 2 respiratory failure or why she's short of breath. From the history, the good thing that you exclude that she has no orthopnea, no paroxysmal nocturnal dyspnea, and she has no swelling, so unlikely she has heart failure. You exclude that as apart from this examination. However, still you are thinking about asthma in this patient, and she has no history or background of asthma symptoms. So I think, and she has no risk factor for that. So this has been excluded. Still, you have pneumonia, but the other thing that this patient have a history of travel. The only, still we need to exclude PE. This case of a PE patient, this is a real scenario case. She's quite well. She's going to Spain with her husband, and most probably this lady have the PE in her first travel when she go to Spain. When she came back to UK for over the 3 days, the PE is increasing because now the shortness of breath is increasing. The only risk factor for this lady was this travel. It's just 2 hours traveling. 2 hours traveling history, but it's still she has PE. Okay.
Yes, but regarding the cough, maybe one episode
PE can come with cough, fever, and palpitation. All
could
these
be more
chest pain,
specific.
all these symptoms can be for PE. All these symptoms, dry cough or cough with sputum. This is when it's central PE. But if the patient have chest pain, have cough, have fever, even fever, this can be symptom of PE still.
Yes,
Okay.
Okay, I don't know. Yes, it's they come with fever, tachypnea, tachycardia. It's one of the main signs, but I think would be more of maybe single episode of hemoptysis or pleuritic chest pain. I didn't ask actually about any coughing up blood. Just ask for any phlegm. I think would more specify the analysis. But yes, PE maybe with a chest pain, pleuritic.
It's according. It's become with chest pain when it's near the pleura, because PE, the lung is very big area for PE. So if it is central, if it is central PE, it will come with shortness of breath, with chest pain, look like like it's the elevation MI or like this. And if it is peripheral in the periphery of the lung, then it will be chest pain with pleuritic type of chest pain. So it's according where is the PE. That's why the symptoms will be different. But the main important thing that this patient have progressive shortness of breath, which is not explained any way in a patient normally well, apart from PE. The way of the shortness of breath. You understand me? This PE, this pain, short of breath is increasing, and it's not continuous type of just a short of breath. It's a short of breath that mainly with walking, not at rest, but with activity, mainly with activity.
Yes, doctor.
If it is pneumonia, the shortness of breath will be always. But it's still, I'm completely agree with you. It's still pneumonia is the differential diagnosis. But with this scenario, we have to have a low threshold for PE. The good thing that you ask about the DVTs, and you examine for that, and this is good from the part of examination. We'll go through the same picture of investigation. That's general investigation. We do a chest X-ray. We do for me, this is patient either the Will score is high for me, so I will go direct for CTBA and to exclude PE. Unfortunately, this is a real scenario case, and unfortunately, this patient was having low blood pressure when arrived to hospital, was low blood pressure, and her oxygen sat was very low. This history is not taken from her, in fact, taken from the family. And when so what the treatment if we say this PE?
Yes.
So what you're gonna do?
Yes, but just I will mention that if she developed this sudden difficulty in breathing with maybe there is some signs of pulmonary hypertension, even the examination could be palpable B2 chest crepitation. So maybe the management plan would be different if it's an acute pulmonary embolism and high Wills score. The main would be CT angio to confirm the diagnosis, echo study to confirm that it's affect the heart by looking for any right ventricular strain maybe, and then admission for anticoagulation. And yes, it's the NOAC would be, but if it's acute, the main treatment is fibrinolysis treatment. If it's not acute, like the case you mentioned, no signs of pulmonary hypertension, no signs of strain on ECG or echo study, the treatment would be novel oral anticoagulant. But if acute,
yeah, it will be like stable if she's if it's hemodynamically stable or non or hemodynamically unstable. If it's hemodynamically unstable, then we'll go for thrombolysis therapy, and if hemodynamically stable, we go for NOAC. I mean for what do you
novel.
call novel, yeah. So according to her.
Yes.
In your case, sorry, maybe I confuse you, but in your case, in this patient, she is talking to you. Most probably, she's going for anticoagulation only because she's hemodynamically sound stable.
All right.
Okay.
Okay. I will ask a question on the last point. For how long anticoagulation, Dr. Huda?
Yes,
I guess, yeah, so?
It's depend on whether it's provoked or unprovoked.
You tell me. This case, for how long she will take anticoagulant?
Yes, for in this case would be for no more than 6 months.
Why 6 months?
Because provoked by long travel.
So the provoked 6 months? You are confusing yourself.
Okay, so if it's a provoked, it's a provoked.
So it would be.
I'm confused if it's whether it's less than 6 months or more than 6 months.
3 months. Always remember the provoked means there is reason. So we have reason. I will take it for a short time, 3 months. If I don't have clear reason, which is unprovoked, I will give it longer time because it might be recurrent again. You got it?
Yes.
Okay, clear now. You have to know this question. They will ask you, okay, if the patient having recurrent PE or DVT, for how long she will take the anticoagulant?
It would be lifelong.
Yeah, you have to remember this, especially if there is thrombotic disease, right? Or
Right.
provoked by thrombotic condition like antiphospholipid antibodies or any other autoimmune paranoid paroxysmal nocturnal hemoglobinuria. The disease, we know that it's thrombotic disease by nature, right? It would be, especially with the recurrent one, it would be lifelong. Okay.
Yes, they mentioned if the patient is less than 45 and unprovoked with positive family history of a blood clot, maybe certain factor deficiency with recurrent pulmonary embolism, yes, would be
Yeah.
lifelong anticoagulation.
Yes. So you have to think about family also. This factor laden, protein C and S deficiency. This also will be required for lifelong, as you said. Okay. Well done, Dr. Rada. Yeah, Dr. Mayada, you have any question or comment?
No, thank you. But yeah, I agree with her in the differential diagnosis, but we need just to put the PE. And this patient, I think also COVID can be one of the differential, the previous COVID that would come with
Yeah.
this weakness of rest, and all this can be
Perfect.
one of the differentials.
Okay, thank
I
you,
have
Dr.
one
Mayada.
a question that this travel history is very short duration, like 2 hours. So this thromboembolism, pulmonary embolism can present with such a short travel history?
Yes, can.
Yes, I wrote also in the chat box why 2 hours with elderly patient might have DVT even short time. Those people, elderly, they are mostly or they have possibility to be dehydrated rather than others, right? With another comorbidity like diabetes, it could be a thrombotic trigger for DVT and PA. So it's not necessary to be long time travel, like 6 hours or whatever. In younger patient, you can say yes, 6 hours long time, it's a trigger, but in elderly patient, you can suspect it as a cause. But it's not necessary. So don't say, no, it's short time, it will not be. You have to think about it. PACES exam, they want you to suspect the most serious and rule it out initially. If it's out, go ahead with any other differential. Okay, and this is also in our practical life, not only PACES, right?
Yeah, but what confusing is, she have a difficulty in breathing. I think it's when I take the history, it's more of a severe symptoms of difficulty in breathing.
Yeah.
Progressive
I will tell you
short
now.
of breathing.
I
Progressive
wanted to
short of
say,
breath over 3 days.
with activity, with exertion, and it's sudden onset. So I don't know why I put PE at the
Unlikely, yeah.
last. Yes, because yes, long travel, yes, could be 2 hours with this age, but maybe DVT signs or symptoms, hemoptysis maybe once give a clue, maybe the chest pain, but I think PE could be the differential even with these
Yes.
mild symptoms.
Always put the serious on the top, Dr. Huda. Your exam is near.
Dr. Batem, I wanted to add one.
Yes.
In our real patient, and the only presentation for cancer is pulmonary embolism. Yani even patient did not travel anywhere and there is no any
This is another thrombotic agent. Yes, you're right.
Even patient not travel, patient came from home and only with palpitation, no shortness of breathing, nothing. And patient only, when you do ECG, only sinus tachycardia. So we will investigate this patient. We will found this patient pulmonary embolism. And then we should look for from where come. You do DVT, ultrasound, Doppler, nothing. So you do X-ray, do CT, abdomen, chest, pelvis, you found there is a cancer in the recta, in the colon, in the lung, in the anywhere. And there is no weight loss, no constitutional fevers of night sweating fever like this. So any patient with sudden palpitation or sudden shortness of breathing or sudden pleuritic chest pain, this possibility of pulmonary embolism is number one.
Yes, perfect.
I wanted to ask a question. If we, not only in this scenario, in other scenarios, Dr. Huda did work and take history very good, and they go up and down in the history and do examination of the patient. How basis will such scenarios, not only in the acute settings, but in all, يعني even chronic case or acute case, how he will يعني give us the marks in such a case? I wanted to ask this question.
So you have, again, as I said to Dr.
Yes,
Huda,
we take history. She take history
yeah,
very good and ask about weight and fever and everything. She take a very good history and she
yes,
examines the patient. But
I
when
agree.
she the differential diagnosis and she make pulmonary embolism يعني little wise
Less likely,
away.
yes,
Dr.
yeah.
Yes.
Bassem,
She examiner, how the examiner will put the marks for us?
Yeah.
if you excuse me to answer this question, I asked this question twice for two mentors. If we took good history, complete history, I mean, with everything, drug history, social history, family history, systemic review, everything, but we did not reach the diagnosis. And of course, the result will be that when they are asking about the differential diagnosis, you will get some marks. When they are asking about the treatment, it is according to your answer, but you will not get full marks because you don't know the diagnosis. So
No need
how
for full mark, but only to pass. Because
yeah,
if you see,
they said, Dr. Mohid, they said both mentors answer the same answer. They said you will get about 14 to 16 according to the examiner.
Yes.
They will give you in the welfare form if you did not do anything, the history itself, and I think another thing they make it for me communication. Yes, they make it for me 14 to both same answer. 14
Okay.
to 16 only.
Because I wanted to tell you, the examiners are not يعني good persons. يعني if I go with pneumonia, he say, okay, he will not correct me. So the
Yes,
patient
I will tell you now.
what I have, I will tell him you have pneumonia and I will admit you and give you antibiotic. The examiner will not correct me when I sit with him. He say, okay, pneumonia, then what is the organism? And he knows the case is pulmonary embolism. So he will affect me in the concern and in the clinical judgment. صح? 0
Yes,
0.
and differential as well. Differential.
And
They
differential
call,
also we will pick 0, صح?
yeah, they will in feedback, you know what they are writing? I saw by my eyes
Yes.
feedback with this
Yes.
comment, linked skill. What the meaning of linked skill? Linked skill means you based an answer on a wrong diagnosis. So what will have wrong and the mark will be deducted, and the clinical judgment will be deducted because you didn't reach the diagnosis. In the differential, you didn't put pulmonary embolism. In the concern, because you answer as no pulmonary embolism. In the examination, if you didn't rule out the examination of pulmonary embolism, also it's linked skill. So all marks will be deducted. As Dr. Salma said, you might get half mark in each skill, and the mark, if he's kind examiner, he might give you borderline, both of them borderline, and you can get half the total mark, 14 out of 28. I believe you have to mention the acute and the possible acute differential in the top. Why? You have to be safe, doctor. Patient presented with acute symptom and complain, you have to suspect the most serious diagnosis. like in this case, patient presented with 2 days history of chest pain or short of breath. What I should suspect, and I put in my differential in the paper, MI, acute, because it's sudden onset. The PE, pulmonary embolism, pneumothorax, this is what we know. All of us know the causes of severe and acute chest pain or short of breath. So again, chest pain or short of breath as acute, either pulmonary embolism, MI, or pneumothorax, or pleurisy, or atypical chest pain related to myositis or whatever. Please, in any chest pain scenario or short of breath scenario, write this differential in your paper. Roll out one by one, and whenever you have some suspicion of any of them, put it in the differential and in the concern. You will lose the mark of all the skills or most of the skills if you didn't mention this serious differential. Clear? Pneumonia, I
The problem,
agree.
sir.
Yeah, agree.
problem,
You
sir,
can
in-
say the
Doctor-
pneumonia, Dr. Muhi.
Okay, sir. Okay. Dr.
Okay, but-
Mayada wrote in the scenario, patient presented with shortness of breathing. So while I'm still outside, I don't know the shortness of breathing is acute or chronic. And all the diseases of the medicine cause shortness of breathing. Systemic
Okay,
sclerosis,
let me-
acute kidney
Okay.
injury do shortness of breathing. Yes.
Okay, I will help you. I will
Yes.
give you a clue. I will give you a clue. Usually, in recent diets, last diets, they put one acute and one chronic. So if you have two long clinical consultation scenario, you will have one as acute one or acute presentation, and the other will be as a chronic. Okay, this is the first clue. The second clue, in your paper, the paragraph they will write for you for how long duration. We are practicing a vague symptom or a vague complaint, but in the exam, you have full paragraph and full details about the vitals, about the history, not history, about the complaint, when exactly he has acute pain, chest pain, or he came with 3 days, or at least they will write for you a clue about the duration. Okay, he has a chest pain for a long time or short time. So you write in your paper differential diagnosis of short or acute or chronic. As well as the vitals. You have to look for all vitals. In this scenario, I believe Dr. Mayada, if she wrote vitals in this scenario, she will write saturation 88, 90, 92. It will not be more than 92. Why? Because always the PE, pulmonary embolism patient present with hypoxia. So please look at your paper, focus on every word from the patient name, the task, the complaint, the vitals, and put your scheme, put your differential, always roll out the most serious. I said it before. Why you want to roll out the most serious? Because according to this differential or according to this cause, either you will admit the patient or no. And if you admit the patient, you get the mark. If you didn't, maybe you will lose the mark. The second thing, you have to put a plan for the patient and differential. If he has something serious, you put it in the top, and he will give you a question related to this. Doctor, is it something serious? How to know? So from your question, you have to know. From history, you have to know. This is the way it's a skill, and you have to be smart while asking, while taking history, while doing examination. And every social history here is important. I like when Dr. Mayada ask about the pet, the cat, any. You have also to ask about any asthma trigger, Dr. Mayada. I guess you ask any change of your painting or neighbor painting, right? This is also for asthma exhibition, especially if the patient is having asthma. One more thing and one more advice for Dr. Mayada. Whenever you have chest symptoms,
Dr. Huda.
Dr. Huda.
Yes.
Yeah, Dr. Huda, whenever you have chest symptoms, analyze the chest completely. I mean, cough of blood as you miss, you said I miss it. So you have to ask it. Cough of blood, cough, any phlegm, any noisy breathing, any runny nose, any short of breath. All this question you have to ask them. It might be a clue for your case. again, we are learning from the mistakes and the session. If you have travel history, even for 1 hour, put the DVT and PE possibility. Why? Because I should be safe. If I ignore it, the patient will die. Maybe he will have, she will have another PE and she will die from it. And this is also our practical life in the ER or any doctor working here. Patient came with severe short of breath or severe chest pain. Initially, you are doing D-dimer, right? ABG, chest X-ray. Why? Because we are suspecting pulmonary embolism. If not, and I have chest pain, typical chest pain radiated to the shoulder, to the jaw, I will do troponin, right? I should rule the serious. If I ignore the chest pain due to cardiac cause and I didn't do troponin, I didn't do ECG, I admit, I said this is atypical, please take some analgesic and go home. Maybe he will have another myocardial infarction and he will die. So why I should be safe? Because if I ignore something serious, even in atypical chest pain, what the problem if I did troponin? I suspect something hidden in this patient, diabetic patient. He has atypical chest pain. So he's risky to have MI and silent MI. I should do troponin just to be sure. And by the way, they are repeating the troponin after 6 hours to see if it's trending up or it's same or it's nothing, just a typical chest pain. Be safe in the paces. Mention the most serious and which makes sense. This is most probably this is the case. In this scenario, travel history is a clue even for short time, but for the elderly patient, you have to suspect dehydration, you can suspect cancer, you can suspect comorbidity, which can lead to the thrombosis. Okay, clear now?
السلام عليكم.
عليكم.
عندي بس كومنت على الريماركينج و
Yes, go ahead.
question. Okay. My comment was the marking even in the clinical, like in the chest or abdomen station. Okay. Mainly in the chest or abdomen station. Because usually the investigation will be the same, the differential diagnosis usually it will be like similar. Okay. For each cardiac case. Like if you miss like spleen, okay, and it happened for me in the exam, okay, if you miss spleen or liver, then you depend on that. If they give you unsatisfactory in the clinical sign, okay, it will go for your differential diagnosis because they were right based on wrong finding. It was just for Ballar.
Yeah.
It was for me for Ballar. I just mentioned in Ballar and all like because the investigation, even he write it is good workup, but based on wrong finding. Okay. This is for the marking. So if you just give a wrong differential diagnosis or you give a wrong finding, it will be like you miss totally the case. They are very tough in these things. My question about the other thrombolytic risk factor, like paroxysmal nocturnal hemoglobinuria,
Yes.
and SLE in 70 years old. Because it is old, I think I need to ask about this question in such case, like 70 years old, or because it will be less likely to be happening in old patients.
No, but one question can roll all this out. Doctor, I believe Dr. Mayer, Dr. Hoda asked very nice question. Any history of previous clot? So previous clot in this patient with no past medical history means all the inherited or any autoimmune, because I cannot ask in each condition in this patient age.
I think in young patient, we need to ask all.
Yes, I agree with you. Yes, I agree.
But in old, we can just ask a question like I can ask about, do you have any background, past medical history of any medical disease I should be aware of, any chronic disease you have, or in any medication you are taking.
Perfect.
It will be exclude for me this other.
Yes, I agree with you. And don't forget the birth control pills. It will be one of the important in young patient. Of course, this patient will not have a menstruation because already menopause. So I
Yes,
cannot ask
yes,
about the family history. But previous
yes,
blood clot in question in this age is very important question.
yes, 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 yeah.
Doctor, regarding this case, yeah, why clinical judgment would be affected? Because in this case, the pulmonary embolism does not like it's causing hemodynamic instabilities. So in this case, would be no role for admission. She only have this tachycardia, but
The
could be
severity,
managed.
Dr. Dr. Huda.
I think here, sorry, okay.
Yeah, go ahead, Dr. Ahmed, yes.
Yes, because we can say it even for admission or no, you tell him, we need to review your medication, your investigation first, because it is not just about the symptoms. Even CT pulmonary angiogram will give us clue, because sometimes the patient will be stable on arrival. But when you see the CT pulmonary angiogram, it will be like maybe his body is compensating. It will be massive, okay, clots. So at that time, maybe you need to be admit the patient.
Yeah, in addition to this, Dr. Ahmed, I remember, sorry, Dr. Huda, I just listen to this. I remember Dr. Mayada told you she is a part of other, she is short of breath, right? She said it clearly. I remember this word. She said the patient is short of breath or difficulty of breathing, right?
Yes.
So this is another clue. You have to know till what level she is short of breath. Is there any drop of oxygen saturation? Is she comfortable to talk? Is she restless because of hypoxia? Does she continue or complete the sentence? So we have to know what the limit of short of breath for this patient. And accordingly, I will admit or no. Don't tell me that the patient will come to you short of breath in the emergency and you will tell her, no, you are fine. I believe you don't have anything. And she's tachypneic, right? Or saturation is 90. There's something hidden. So you will know it. By the way, Dr. Huda, I'm saying that because in the exam, everything will be mentioned, saturation. So don't worry about this. And the surrogate as well, they are helpful. They are not hiding. If you ask something clear, they will answer you clearly. Okay.
Can we put pneumothorax also as a differential diagnosis in this patient?
Okay, perfect differential. But what do you think the trigger or the cause of pneumothorax in such age?
Just idiopathic, it could be like if she's
So you
smoking
have,
or something.
yeah, she deny any,
Just
she's the
as,
smoker?
yes,
Yeah, I agree
I
with
don't
you.
know. But like we can put it in the list, not in the top.
You can say it against pneumothorax that the patient is, for example, doesn't smoke, or
Yes.
why you didn't think about
No,
pneumothorax.
no trauma, no history of
Perfect.
trauma.
So
No.
let's mention the possible cause of pneumothorax, the trauma, as
Yes,
you said. What else?
yes. It could be background disease, like if she has COPD
Perfect.
or
Yes.
yes,
So against that, no COPD, no trauma. Against
yes,
that, no smoking.
yes. No
All
smoking.
these
Yes,
triggers, if not in the history, I will tell if I'm suspecting severe chest pain or short of breath, I will say against that there is nothing. Marfan also one of
yes,
the possibilities. Marfan syndrome also one of the possibilities.
yes.
Okay, Dr. Huda, any other questions? Thank you, Dr. Ahmed, for this nice discussion. Dr. Huda,
Thank
any
you.
question?
Thank you, Doctor. Nothing much.
Okay, you're satisfied now? You
Yes,
learn
I
from this
think
case?
I all the time practice such cases with shortness of a breath, and all the time I put PE the last, but I think yes, it should be and my top differential
MI as well. Yeah, MI,
Am
don't
I
forget.
yes, but she okay regarding her age, okay, female, maybe silent. Am I? But no chest pain. Why silent? Am I? I don't know. But it should be one of
Yeah.
This is
Okay.
differential.
Take home message, Dr. Huda, because we will gonna take a vacation till Eid. In this period, read about the possible cause of acute abdominal pain, acute chest pain, acute short of breath, acute headache, because you might have a scenario with acute presentation and the other scenario will be chronic. The chronic one already we mentioned and we practice them a lot. But the acute thing, maybe we didn't practice with them a lot.
فعلا والله يا دكتور باسم كلامك جميل خالص والله الحقيقة. acute chest pain, headache, abdominal pain, acute joint pain كده الحاجات دي
وجوينت
very
pain, yes, yeah.
صحيح.
I
عشان
believe,
كلمة سيف دكتور دي to be safe دكتور.
yes, yes. You might
لما
say
يبعت لي
diagnosis.
بالفيدباك كده you are safe unsafe دكتور يعني كلمة مهينة جدا الحقيقة.
Dr. Ahmed said correct comment, and I saw it my eyes. Linked skills. So 4 skills might be affected by the mark if you miss the diagnosis. For example, started by the identify the finding. If you didn't suspect PE here, you will not do the chest examination. You might think about heart or abdominal. Or, I mean, this is one of the skills will be affected. The second skills will be clinical judgment, the differential diagnosis, and finally the concern. Because you are talking about something away from your diagnosis. You said this is pneumonia, and you are talking about you might have a bug inside your chest, but it's not the case. This is the mark for concern. It will be harm, of course. You didn't talk about pulmonary embolism at all. So please think always about the acute cause. In the group, by the way, I put for every system message summary, what is the possible cause of acute abdominal pain or acute chest pain or acute headache. You can read it in
شوف
the
بعتها لنا تاني الله يكرمك.
sorry,
بعتها
you
لنا تاني
didn't.
بعتها لنا تاني
You see the
البوست ده.
collection of practice cases with every system,
ايوه
you can,
مم.
yeah, there is some written notes, or it will be there included.
مم.
Anyway, I will share it again. Just to revise, Dr. Huda, don't worry, you are in the right track. You are doing much better than before. Just add some comments and some advices to your performance. Try to train on this period. Hopefully, we'll be back after Eid. Of course, the priority is still with you. Your exam will be after Eid by, I think, by 1 week or 10 days.
Yes, yes.
Yeah. So again, anytime
Right.
you will be the one to practice with any other member. I think no one have exam near like you.
Me, sir, me next month also.
Next
I
month.
have exam.
Yes, you will be prior also, but Dr. Huda, 12th of April.
Yes.
I guess Dr. Mahi is still in the May.
Yes, in May.
Yeah, so still we have time. No worry. Okay.
So from this practice session, what I learned more, I have issue with the differential diagnosis. My
Yes.
differential diagnosis is weak, and the investigation treatment plan. Yes, I noticed that from this practice session. Yes, the differential are my problem. Especially this difficulty in breathing, shortness. I feel 2 times because of this complaint. Yes.
Okay. Try to watch more videos in the sessions. We always practicing and mentioning the differential for each scenario. The second thing, for the investigation, please don't mention just blood test aspiration. Go systematic. You will waste time and you will save time also. How? You will waste 1 minute or 1 minute 30 seconds mentioning just the steps or the system of your investigation. General investigation, specific investigation, bedside investigation, imaging, and invasive test. He will choose one of them. Of course, he will be impressed by this answer, okay? Then he will ask you Please, doctor, don't tell me about the general. I need specific. What do you mean by bedside test? In this patient, as Dr. Mada said, you will do ECG, you will do echo, you will do ABG, you will do pulse oximetry, you will do chest X-ray, all these bedside tests, which is also inconclusive, right? And you impress the examiner with them. Don't start by, I will do CTPA because I want to roll out PE. Yes, it's one of the priority to do this image, but put it with the image. Try to make, and before the CTPA, you have to do 2 tests. What are they, Dr. Huda? Let's revise. If you are planning to do CTPA for a patient, what test you could do initially?
Or CT pulmonary angio.
Yeah,
Mm.
there is 2 important tests. One related to the case, and the other related to the patient systemic or general condition.
Maybe D-dimer.
Perfect. This is for the case here, right? D-dimer. What about the general condition? What do you think I
Yes,
have to screen?
echo study.
No,
to
blood
check
test. No, blood test. Yes.
clotting. Sorry. Yes, renal function.
Yes, renal function test. Why? Because if this patient is having kidney injury or high renal function test, I could think about other tests before proceeding with the contrast. I could do CTPA, pulmonary angio, and it might be negative, and it might be negative for PE. I just give a risk of exposure to contrast for nonsense diagnosis. I don't mean this case, maybe another case. So you have to do renal function test. If there is high or borderline creatinine, I could think about other tests. So what other alternative tests for PE, Dr. Huda?
Yes, ventilation perfusion scan.
Perfect. Yeah. But also you can do before then non-invasive test, which is called what non-invasive tests you could do in this patient before proceeding for CTPA? After D-dimer, of course. D-dimer is positive, and you suspect.
Doppler study.
Perfect.
Echo
Yes.
study.
Yes. Doppler study, venous Doppler study to rule out DVT. VQ mismatch if I have kidney function or I have contraindication. By the way, the pregnancy is not contraindication. They are putting shield, abdominal shield, and they are proceeding with the CT pulmonary angio. Okay. It's not contraindication, Dr. Rashid. They are doing it with abdominal shield. Okay. Yes, I agree. Nice cases today. You have any question, Dr. Hood? Dr. Huda?
Thank you, Dr. Bassel.
Most welcome. Okay, I will try to read the comments quickly. It was acute onset. Yeah, this is my comment. Duration of pneumonia will not be presented with 1 day or 2 days. She will say, Doctor, I have short of breath for almost 1 week, and it was over the last day. So it will be longer duration than the acute presentation of pulmonary embolism. Yeah, Dr. Rashid wrote she denied chest pain, but she said, I am short of breath. I believe it might be denied, but maybe also it can be positive in this scenario. Hemoptysis, yes, you have to ask about it. COVID, I believe also you have to ask about COVID vaccination if you suspect COVID, because it's one of the new trending cases presentation. Pneumocystic, yeah. If you have AC problem, you can think about Legionella ventilation. Patient stayed at hotel and after that he had pneumonia. So I would think about Legionella infection. If I am having patient with TB, I could suspect pneumocystis BCB. Or if I have patient with rheumatoid on methotrexate, I could think about BCB. If I have patient with HIV, I could think about BCB. And it comes in the exam, by the way, Dr. Rahul. Pulmonary embolism, yes, again, one of the important. Whenever you have patient, this advice is very important, Dr. Huda. Whenever you have patient with short of breath and saturation is 90 before doing anything in the history, are you okay to proceed? Do you need some oxygen? He'll tell you, yes, doctor, please, I'm very short of breath. Here you are. This is the oxygen. Then, are you okay now? We can proceed? Yes, doctor, proceed. It's an act. again, you have to act like in a show, okay? Tachycardia on examination is very important, and by the way, tachycardia is very sensitive sign of PE. It's I think 90 plus sensitivity. If you have patient with tachycardia, it's a clue for PE. Apart from tachycardia and ECG, S1Q3T3, one of the questions, what the signs of PE? Okay, Dr. Mohi said, I know the diagnosis. We know already the diagnosis now. Palpable B2, GVP, hospitalization, heart condition. Dr. Salma, when she was young, yes, I agree with this also. If you have suspicious of any hobbies like dealing with birds and plants, yes. Perfect. Vaccination is important. Yes, Dr. Rashid. Travel short of pay, we should exclude PE. Dr. Ayman, from the first comment, he catch the case. So travel by any duration, you have to suspect PE, even it's not going with PE. Put it in your mind. Try to rule it out again by other question. If you rule it out completely, you can put it in the second differential. And Dr. Huda also asked about if I put the differential and the case diagnosis in number 2 differential, I can get the full mark. But if you put it away from the third differential, you will lose a lot of mark. So unless it is the first differential or the second, the marks will be deducted a lot. Okay, the onset, the gradual or onset, acute, yes, I agree. Type of calling machine, yes, an important question if you suspect Legionella again. Okay, we made this session longer with some discussion, with some question, advices, because as I said, it could be the last session before Eid vacation, because we have also last 4 days of Ramadan, just to pray, to give us for our prayers, and to take a vacation before Eid. Wish you, all of you, Eid Saeed, inshallah, or Happy Eid, as they said. Any question before ending the session?
Thank you
Any
for
question?
great effort. Barakallah feek. Jazakallah khair.
Thank you, Dr. Rashid. Eid Mubarak, inshallah, all of us. Thank you, Dr. Abdullah Hashim. Okay, Dr. Abdullah Hisham, sorry, Abdullah Hisham. Many thanks. So, okay, see you, inshallah, after Eid. And I will write in the group when exactly we resume our daily sessions. And I will try to refresh the group with some sessions, previous session. Anyone has time, please listen to the previous videos. It's around 200 sessions. Any topic you would like to listen, believe me, you will at least gain some information. You will gain some differential. You will gain some tips would help you in the future. So if you have time, go ahead. If your exam is near, do it. If not, pray for me. Inshallah, we'll see you after Eid. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.